Hello, Mac. Nice to see your
Here,
face.
here we are again. What a wonderful time. This is great. Loving it. Loving it.
Here we meet.
Let's open up. Come on.
Let's
Tell
do
some
it.
deep, dark secrets.
Ooh, I like it. This one seems like
Only in dentistry.
it's,
Only in dentistry. Just dentistry.
yeah, we can't share we can't pull out all the skeletons, right?
Not yet.
Just the ones involving the TM joint, right? And the skull.
Let's stay focused.
All
Okay.
right, all right. Let's refocus. Let's open up. I want to share a story about a patient of mine. Her name is Kelly. I just saw her last week. But anyway, we alluded on our last podcast that we're going to talk about, clicking, popping joints and also trigeminal neuralgia, also known as TN, right? And Kelly came to my office many years ago. She had the surgery that's involved with trigeminal neuralgia, which I'll talk about a little bit more later, right? It was the one where they actually cut or made a window through the base of her skull and repositioned the artery off the nerve. But we'll talk about that more. Anyway, she's got that beautiful scar on the back of the neck, and I believe she went to NIH. And anyway, like we've talked about before, I'm the 10th doctor down on the list, way, way low. And she found us because she had been to everybody, was on all kinds of medications to mask her pain, dull her biofeedback to her body. And the last thing she had done was the surgical procedure for TN, and which made her feel fine for about 8 months. And then all the pain symptoms she was having, the chronic migraine, headaches, the severe pain she'd have around her masseter insertion around this cheekbone area. But anyway, she was just in chronic pain. She has 2 daughters and was trying to hold a job. It was affecting her in every way. So anyway, I treated Kelly originally. I treated her with orthotic treatment, and I wasn't really sure when anybody's had the surgery with of that for the trigeminal neuralgia. They're harder to treat because their body doesn't always respond the way that I would anticipate it to, because of the impact on the nerve itself. And anyway, we treated her with orthotic treatment and she responded amazingly well. And I did not want to do any orthodontic work on her. She wasn't a candidate for porcelain crowns because she had perfectly healthy teeth. She had had a history of having braces 2 other times. The first time they had pulled 4 of her teeth, her premolars, which are the middle teeth in our mouth. And that right then is what, once they retracted to close up all the spaces, pulled her jaw back. And since then, she slowly started to have symptoms throughout her life. But anyway, I had her in orthotic treatment for a year, and she responded great and stayed stable for quite a long time. And she's like, I don't want to wear this appliance. She was in her late 30s. I don't want to wear this all the time. What's my other options? I was like, orthodontic treatment, but just be aware that through treatment, because while things are moving, you can backslide. You can start to have some of your symptoms can resurface. You'll never go to ground zero again. I felt confident at that point because it had literally been almost 12 months and she had been doing so well. And so we cautiously both agreed to move forward with orthodontic treatment. And Mac, she's doing extraordinarily well. Like it's been, I want to say like 7 years. I see her just, for recare, comes in for cleaning. I also see her just once a year to check the joint, check her muscles. Because of the damage to the joint and the nerve, she can regress and have episodes if she's not taking care of herself. It's like having bad hips, I can get your hips working right and your muscles working great, but some of the damage has been done in an adult, right? So you've got to take care of yourself. Otherwise, you'll get triggered. Never back to zero, but get triggered. But man, she was so grateful for the treatment. And, again, just sad that she had been through so much and had suffered for so long and was incorrectly diagnosed. Again, some of it, no disrespect to other colleagues because they might not know, but they don't know. But I'm curious, like, how can you perform treatment on some people when you don't know how to actually analyze all aspects of that condition, right?
Right. And so in everything we do and MDs do is that you have to have a differential diagnosis. Differential diagnosis meaning, is it TMD? Is it trigeminal neuralgia? Is it migraine? Is it cluster headaches? those are all supposedly separate entities, and I'm sure they are. Okay, so I have asked neurologists before, because they're the ones responsible for diagnosing migraines, which is the same symptoms as your TN, not necessarily, because TN's got all of the skin issues, but everything's so similar. Okay, so let me ask you this. If you had an exposed nerve and you pressed on that nerve, what would happen?
Mhm. It's gonna
Yeah,
hurt.
you're gonna hurt.
Right.
Okay. So the root of the trigeminal nerve, which operates not all sensory, but almost all pain in most of the sensory of the face, makes the five fingers like we talked about in the first episode. Every pain that you have in your face is due to the trigeminal nerve. You can just basically. So trigeminal neuralgia is a pain in the face. Okay, so because it's a pain in the face, they seek medical treatment.
Right.
So you mentioned a misdiagnosis several years ago. It was a misdiagnosis. Now, if a neurologist or MD who's responsible for diagnosing trigeminal neuralgia, migraine, cluster headaches, has no education, they're completely unaware of TMD other than a clicking joint, how can they possibly make a differential diagnosis?
Right. God, that's such a good point.
Or an MD who is often wrong but never in doubt, who diagnoses all headaches as migraines, or severe headaches is trigeminal neuralgia, when the trigeminal nerve passes right by the joint and can be squeezed and irritated and inflamed
Mhm.
by a bite that is not in harmony with a
That's right.
person who is sensitive to things other people are not sensitive. And sensitivity is sex, it's hormones, it's a lot of things, it's stress. It is truly a biopsycho social issue. Bio is the mechanics of the mouth. Psycho is where am I in my life? Am I stressed out? I mean, what my kids are doing? And social is can I pay for it? Do I have family support? All of these things come into play no matter what. If it's TMD, if it's TN, trigeminal neuralgia, migraine, or cluster headaches, it all comes to play with the diagnosis. But if you don't know all of these conditions, how can you possibly do a differential diagnosis?
Uh, Beautifully said. Beautifully said. And for our listeners, um, trigeminal neuralgia anatomically, specifically, is the compression of that trigeminal nerve, which is one of our 12 cranial nerves. This nerve is a sensory nerve and a motor nerve. Sensory meaning, like Mac was just saying, it depends on the literature, 70 to 80% of our feedback to our brain about what's going on and with our face, where our body is proprioceptively, meaning spatial relationship. And it also controls the movement of a lot of our jaw chewing muscles, our masticatory muscles, and facial, some expression muscles. But anyway, this is a huge nerve. And anatomically, if it's compressed by an artery, just because of the position, that is what causes trigeminal neuralgia. Anatomically, that's what causes it. Now, the symptoms that come from trigeminal neuralgia, like Max said, are very much under the same umbrella of TMD. So it can be easily misdiagnosed if you're going just based off of how someone's feeling, their symptoms, right?
Right.
So there are three ways the medical profession, I believe, there could be more now, I don't know, but there's three ways that they're treating them because I've seen a lot of their post-operative patients for treatment. One is the one I was just telling you about, Kelly, where they do a surgical incision right behind a patient's ear. They make a hole through the base of the skull, and they actually reposition that anatomy to get the compression off the nerve. Because it's like you said, it's not that the nerve is exposed, but if you're pushing on a nerve, that hurts. It hurts to the point that even if wind goes across their face, it's like electricity. It's like their face is on fire. That's totally different than a TMD issue, right? So that's one
Absolutely.
way to do it. The other way they do it is through microvascular decompression surgery. I think it's MVD is the acronym for that. And that's less invasive. They don't actually go in there and surgically make a hole and move things. They use radiation beams to kill parts of that nerve, the trigeminal nerve. It's aimed at that nerve specifically to damage it. So it stops the transmission of pain signals to the brain. And then the third way that I've seen more recently is rhizotomy, where it's very similar to MVD. They're just doing things to, again, damage part of the trigeminal nerve to stop the biofeedback to the brain. And I don't think I think they know they can't do too much to that nerve because of all the feedback it gives to the brain, the important feedback, and also the function of our jaw and chewing. So they're very limited in what they can do. And while people might have some numbing of the nerve and feel better for a while, if it's a true TMD issue due to a toric mandible, midface deficiency, or posterior interference, is what we've talked about, then the symptoms are going to go back, and they've already suffered that procedure in vain, So that's one of my biggest frustrations, my friend, is like just people being incorrectly diagnosed, maybe because the doctor just didn't have the time to spend with them and listen to them, like you always say, or they just didn't know what they didn't know.
Yeah, and so I go back to 1968, sitting in an anatomy class and learning about trigeminal neuralgia. And back then they did a surgery. So, and again, I'm not an MD and I've been away from all this for a long time. But isn't it true that they treat at the foramen part of the brain where the nerve comes out? At least that's what they were doing back in 1968. So there's a difference between the nerve coming out of the brain versus the pressure that's occurring here. Now, trigeminal neuralgia is real, and the diagnosis is extremely important. But because there's a vast awareness of TN, because it's been around so long and it's so painful, there's not an awareness of TMD worldwide. So again, the physicians are going to have to learn to do a differential diagnosis between TMD, as you said, because it'll reoccur, TMD or TN. And both of them are individual systems that do cause pain. I'm calling for awareness. That's all I'm calling for, just awareness for it.
It still dumbfounds me why the two professions, why we can't collaborate and have conversations to take care of people globally. It's like, I'm not pretending to know everything that a neurologist does. That's way past me in many levels. I get and respect that. But, why is it that they know nothing about the mouth and the way the teeth fit together? It doesn't take rocket science or many years of education for you to look at somebody's mouth and see if their teeth are all jacked up. Then there could be a masticatory issue causing TMD that is causing some of these problems. Why can't we talk about these things? Man, now you got me going.
Good.
It's like,
open up.
man, this week, oh man, I'm probably gonna be in so much trouble on this one. But the ear, nose, and throat doctors, they're freaking killing me. They're killing me. I'm treating all these children because they have airway issues we've talked in the past, and I'm trying to stop this horrible craniofacial development they're on the path towards, but they have giant tonsils, giant adenoids, and they have their turbinates are all swollen because they're allergic to everything under the sun. I send them to the ENT with an eval, with a radiology report, with a copy of my 3D scan that they don't open up and they don't bother to read. And they tell the parent, here's some Flonase, everything's going to be fine. And they're going to grow out of their freaking tonsils and adenoids. And then the parents come back looking at me like I've got two heads. And I'm not going to sit there and argue against our medical colleagues. But
No.
man, what the hell are we doing? I don't get it.
So when they being whoever, another dentist, another ENT physician, are looking at a cone beam, and a cone beam shows you joint position, it shows you the bone, it shows you the relationship of the condyle to the skull. And when that condyle, which is supposed to be rounded, is changed in shape, changed in morphology, they diagnose it as arthritis. How can you do a differential diagnosis between arthritis and compressed joint? A compressed joint, compressed bone is going to change in its morphology.
Yes.
And when you have an incorrect bite where the jaw goes backwards for many reasons, and that joint is compressed, it is going to be remolded,
Right.
reshaped, eaten up. On the
Mhm.
x-ray, it looks just like arthritis. So how does an MD differentiate, or an oral surgeon or anybody